Good afternoon, everyone, and good morning to those of you joining from the West Coast. I'm Rebecca Parks, the Chief Operating Officer at T1D Exchange, and I will be moderating today's webinar and introducing our speakers. We will be taking questions at the end, so please submit them through the Zoom forum using the Q&A button on your screen. To get started, I am pleased to introduce our speakers. First, let me introduce Dave Walton, Chief Executive Officer at T1D Exchange. Dave joined the T1D Exchange board in 2018 and in November 2019 was appointed CEO. Dave has 25 years experience in the healthcare industry with more than half of that time spent in diabetes in commercial leadership positions. Following Dave will be Dr. Osagie Ibekosian. Dr. Ibekosian joined T1D Exchange as a consultant about 4 years ago and in October 2019 joined as Vice President of Quality Improvement and Population Health. Dr. Ibekosian came to T1D Exchange from the Boston City Public Health Department, having led nationally awarded QI projects in flu, HIV, and type 2 diabetes. Dr. Ibekosian has 15 years experience leading multi-site population health projects. Following Dr. Ibekosian will be Dr. Wendy Wolf, our Vice President of the T1D Exchange Registry and Research. Dr. Wolf has been with T1D Exchange for 4 years, and over the last year has worked to launch and build the T1D Exchange Registry cohort. She has over 18 years experience leveraging patient cohorts for health research. Now I will turn over to Dave.
Okay, I'm just waiting for control. Let's see. Well, while we wait for control to turn over here, greetings from the East Coast. I'm Dave Walton, CEO of T1D Exchange, and I'm excited to be here today to talk to you about some of the exciting developments here at T1D Exchange. And looks like we are not advancing the screen. Just one sec. Okay, we are set. So the past few months have certainly been different for a number of us. Earlier in the year, I had planned to fly down to Tallahassee, Florida to join my sister and her family, including my 11-year-old nephew there in the center, to do our first joint JDRF1 walk together, as he and I both have type 1 diabetes. Unfortunately, Corona intervened and we had to adjust to a virtual effort, which included us walking in not as sunny Pennsylvania as Florida. But nonetheless, we adapted, and I think a number of you have figured out lots of ways to adapt to a different way of doing our business. Certainly, we also had planned on joining a number of you in person in Chicago. And we decided after seeing what was taking place early that while we couldn't have an in-person meeting to talk about the 10 years of T1D Exchange and highlight some of the important initiatives as we had planned, we could do a webinar and try to do the same thing, albeit sans the drinks and appetizers. But I am going to take a few minutes to highlight some of those programs of ours, and later on we'll turn it over to Osagie and Wendy to go through some of the detailed information about the developments, some of the interesting things, some of which you may have even seen today via press release on a COVID study. I certainly would be remiss if I didn't start with an enormous thank you to the Helmsley Charitable Trust. The 10 years of T1D Exchange has been made possible due to their generation and ongoing support, and we are very appreciative that support continues. I know a number of you who are listening to this webinar today likely also are receiving some type of support support to manage through these tough times, providing devices to patients in need, et cetera. So again, certainly a heartfelt thank you for their efforts. At T1D Exchange, our mission is not terribly different than a lot of other organizations involved in the diabetes community. But we do focus on a couple of key concepts. Obviously, improving outcomes is something we can all stand behind. But we're doing it through real world evidence and figuring out our place to really have an impact through collaboration and nearer term change. And those have been some of the points of emphasis, and certainly as I took over last year, where T1D Exchange can focus, and that is what we're planning to talk to you about. Historically, a lot of you hear T1D Exchange, and you think about charts that you've seen repeatedly at prior ADA meetings, perhaps. Last year, a number of you saw the Foster work that was presented and shared in a number of different presentations that showed that A1C for the population has not improved, and certainly not like we would have liked to see. And despite all the technology advancement, education efforts, provider commitments, it's still a difficult thing to move the needle. And that's something that we certainly have become even more focused on at T1D Exchange. I do want to spend a little bit of time talking to you about the distinction of where we're at now in terms of emphasis and the types of programs, because it has shifted over the years. As we look at now kind of four key focus areas, the Quality Improvement Collaborative being the first. That's a collection of 15 diabetes centers that work together and work with us to try and improve the outcomes at their individual institutions, as well as others in the collaborative and beyond. And there are certain things that we test and learn and try to proliferate throughout the collaborative. And Osagi will be taking you through a lot of information around that I think you'll find very interesting. Our online patient registry. And this is something that is a bit distinct from the past when you think of the T1D Exchange Registry. We are gathering data directly from patients via online survey and gathering this longitudinal data in a study to elucidate some of the outcomes and intersection or interaction of different tools that they may be using, different devices, and really trying to kind of highlight some of that patient perspective on outcomes. And so Wendy will go through that a bit later in this webinar. We have some custom research that we'll highlight briefly as well, qualitative and quantitative work that may involve the online registry or the quality improvement data that we collect, or it can be custom novel research that we do through interviews and focus groups and surveys. And lastly, I will talk a bit coming up here about our online community that some of you know as GLUE, which is one of the earlier efforts of T1D Exchange, and what we do with some of that information and maybe how you could work with us. So data is obviously core to much of what we do and is a companion aspect of these programs. The online community that I mentioned, we have a lot of email addresses, primarily from individuals with type 1 diabetes, but also parents of those children if they happen to be younger. And there's a lot that we do within that. I'll talk quickly about that. The registry, we now hit over 8,000 people registering for the program, and some of those people are still in the process of populating all the responses so we can get all the data. But we've got a rich set of data already, and there's a lot of interesting analysis, and Wendy will show a little bit about that. I mentioned the collaborative with the 15 clinics that see about 34,000 patients. We have different amounts of longitudinal EMR data from a number of these clinics. And are looking to build that, with further clinics, and that's been a big push for us this year. And lastly, off to the right, you'll notice some archive data that still is available. This is the older data set that was used in the past for the T1D Exchange Clinic Network Registry. So that is something that we still have access to, but we no longer, there are no new patients going into that. It's kind of a retired effort, but we still have access to that data. So briefly on the online community, we have the ability through questions of the day to get a pulse of topics that might be relevant. And that's how we use it. This is not clinical research. This is more efforts to share knowledge and information amongst the community. And it provides an interesting lens. Obviously, with what's going on currently, there's been some interest around how people may have adapted once the pandemic was first on the radar, and that you'll see on the left here, where initially in late February, not a lot of people weren't modifying what they do. If they were doing something, it was either stockpiling some medication or planning ahead, or some other measure. But interestingly, as we go through and look in May, the topic of telemedicine is certainly an interesting one. And you'll see that almost half of the individuals who responded had already used telemedicine and liked it. So that was certainly of interest. We have looked at a number of things, of ways that with our quality improvement data, we could go and look at any kind of comparisons to people using telemedicine versus not, and how their outcomes may have fared. It's something in the COVID study that Osagie will cover, that we also track that information as part of that. So it's definitely a very relevant aspect. And then finally, 2019, we have gathered cumulatively, or in that year, a lot of data. And there are a lot of comments, and that's where some of the richness comes, is not just from someone answering a single question, but in providing a paragraph explanation from the engaged members who are willing to put in that time. And we have gotten a lot of interesting insights from that. And sometimes this will be used just as a quick pulse check as we scope out something more formal to conduct in terms of, let's say, market research that an industry partner may want to conduct. So again, a number of possibilities with that data. But I don't want to take away time from some of the exciting, more recent things here. So I am going to turn it over to Osagie to walk us through the Quality Improvement Collaborative and the exciting work they've done with that, and some highlights from the COVID-19 study that's taken place. So with that, I will turn it over to Osagie.
Thank you very much, Dave. I appreciate that. And thank you to Rebecca. And another big thanks to everyone that has joined us today on the webinar. So I'm Osagie Bekosian, and I'll be sharing about some of this great work that's been happening in our QI Collaborative. So like Dave mentioned, we have 15 sites, and this is the logos of, these are the logos of some of the sites currently in the collaborative. 10 of the sites are pediatric centers, while 5 are adult centers. We've seen a lot of increased excitement and engagement among a host of new sites that are interested in joining the collaborative. And we're very excited about the direction and the growth that we'll continue to see this year, just with the additional conversations happening now with clinical sites that are interested in being a part of this work. But, we set out to really help answer a few questions when we think about our value. There are 5 critical questions that we work with the principal investigators and at each of these respective sites that are in the collaborative to really try to see how do we use different assets and collective intellect to answer these questions. The first is, do we have the right kind of data to drive real-world improvement? A lot of what we do at the T1D Exchange, it's data-driven, creating real-world evidence for what we do. So working with our providers to really answer those questions of, are we actually collecting the right kind of data? And then we move on to answer, based on what we see, based on the different data sets we have, based on the available data, are we making the best decisions? Are we seeing the right kind of outcomes? And then if we are not, how do we improve clinical and population health outcomes for all patients with type 1 diabetes? But we know we can try out a lot of different changes and not all of them might result in improvement. So we're always critical to find out which of the changes we're testing or trying out is really moving the needle on the outcomes we want to see, or the positive outcomes for the T1D population. And then finally, working with our partners and stakeholders, including industry partners, how do we continue to work together collaboratively, collectively, to generate real-time insights from our data? And I'll show you a few examples of how we're answering these 5 questions in the last few years. So our cohort now for the patient panel, the population health panel, the beautiful thing about this is it's all electronic medical record, full population-based data. So at least it gives us a sense of all the patients being cared for at that clinic or at that center. What are some of the outcomes? What are some of the lab findings, socioeconomic, demographic factors? And we can use all of that kind of information to promote real-time change in that clinic, in that facility, really understanding the other socioeconomic, political, all of the landscape that really happens with making a change from a local site. And we take all this information and then share this across board with other centers that are not even part of the collaborative through documents called change packages, for them to actually see what we're learning, how they can be a part of this change, and how they can test the same ideas in their clinic setting. So the work we do to improve population health as part of the QI collaborative is centered around 3 main focus areas. The first one is on QI processes, and I'll talk about that in the next few slides. We also have a very innovative tool that, to our knowledge, this is really the first thing, the T1D space. It's a QI population health portal that uses electronic medical record data to help support case management for all patients with type 1 diabetes. And I'll show you a few wireframes for that and give you a few examples of how our clinicians are using that to really drive and support change locally. And then finally, we also have a section of our work that is centered around the big data analysis and the policy insights. Some of the current work we're doing now with COVID-19 fits into this bucket area for our work, and I'll share a few examples of that towards the end of my session. So what is quality improvement? That's a big word in itself, and I know some people on the webinar might be curious on, what is that? How's that different from research? In very simple terms, quality improvement is really a deliberate approach for us to make a change in a system, and we're doing this through iterative cycles. So in our collaborative now, we use the model for improvements that was developed by an organization called Associate for Process Improvements and has been expanded by IHI. We ask 3 questions for every project. What are we trying to accomplish? How do we know that a change is going to lead to an improvement? Then what change can we make that will actually result in that improvement? And once we're able to answer these questions with the partners, we move on to develop iterative small tests of change. We start off the change with 5 or 10 or 15 patients. If we see the kind of outcomes we want or are seeing positive outcomes with that small group, we expand it to 20, expand it to 50, and that goes on with iterative cycles until we get the kind of improvements which we're hoping to achieve. Now, if we don't see those sort of change, then we go back to the cycle, we plan a new change idea and test that and look at. So there's the real-time ongoing iterative process, working with patients, working with partners, working with the frontline staff in the clinic to really be a part of a team that can bring in improvement and implementation science to make a change and a difference today. And we've done this for different things, and I'll show you some results. We've spent about 2 years really building the capacity for QI at a local site, quality improvements. And we tested changes to improve depression screening, pre-visit planning. We've also done a lot of work focused on high-risk patients, and we define high-risk patients as those with A1Cs above 9. And I've been seen at least 2 times in the last year at each respective clinic. And we've been able to demonstrate significant improvements, statistical significant improvements in high-risk care, glucose monitoring. And we're doing that now with population health interventions. So on the high-risk project, high-risk phase of our work, we had 5 main drivers that are displayed on this slide here: insulin management, glucose monitoring. I'll share a real-time example of how we'd use improving glucose monitoring, more specifically CGM and CGM interventions, improving access to CGM at some of the participating clinics, how we work with the different clinical sites to actually be able to ramp that and scale that up to lead to improved glycemic management and improve outcome for patients. So some of the sites, we had 10 of the 15 sites elect to participate in this project to improve CGM interventions. And we developed what was called a change package to document what are evidence-based strategies that can help move the needle on increasing access to CGM beyond just a policy change or beyond just Medicaid coverage for more CGM. And some of the changes we tried include redesigning clinic workflows to how does a patient get prescribed CGM, and if they don't have insurance access to that, how do we identify that as a barrier or other barriers, and work with patient navigators, offer CGM training, CGM support, and a wide variety of different interventions that were tested across all of these 10 sites with different level of success, but whatever is successful in one site was expanding and scaling that to other centers. And all of these efforts led to very significant improvements, or what we call shifts, if we're using QI terminology, in the different clinics that participated in this project. So for example, one of our clinics in the Midwest saw a 34% increase, and the breaks you're seeing in the data to your left are actually showing where those improvements became significant. So there was a 34% increase for one of our clinic sites. Another clinic site had a 26% increase. And what we did with these numbers is we actually compared the improvement and increase we saw, and we compared that with clinics that might not have been testing this same intervention in the same states. So that gave us a sort of a control to be able to actually validate that the changes we're seeing are actually significant and as a result of the interventions being tested by those clinics. And just referring to the breaks there. And all of these efforts have led to a 12% improvement across all of the 10 sites that participated in this intervention. And this slide you're seeing, it's what we call the run charts. That also brings in QI and statistical measurements into calculating what are called shifts in these run charts. And so far, we've had 2 shifts in these run charts where we've seen the median across the collaborative really improve to about 12% as of December. The numbers we have for January and February and the early numbers for March also showed a sustained increase in this measure as well. We've seen the same kind of trend with insulin pump use. We had 6 sites take on this as a project, and they tested out a wide variety of interventions, scaled it up, expanded it, and we've seen 2 shifts in this case and a 10% improvement there. We've seen the same as relates to depression screening. We moved from about 10% of participants of clinic participants, patients, I should say, not screening for depression to where we are closer to 65% screening for depression. And one of the data that even excites me as well is we've seen this shift also in the high-risk patients, so patients with A1Cs less than 9. And I should add that all of these interventions I flagged, we've tried these interventions first with a 12 to 26-year-old cohort. Dave had shown the Foster slide that talked about A1C improvement and how we're seeing a peak in that 12 to 26 age range, a peak above 9. So for all of our interventions, we really want to be very intentional around, can we improve care for the highest of the highest risks or the hardest to reach? And then once we're able to demonstrate that we can do that, then we expand that to the rest of the clinic cohort. So all these changes I've shown you have all been tested and shown improvements in glycemic outcomes for that age group of 12 to 26, and now been expanded to the entire cohort. So this slide shows different colors. You see the green and you see the yellow. the emphasis on this slide is we're seeing a lot more grains across the different measures we're testing, and by how much the shifts in those grains, which is kind of validating the differences we're seeing. And for side notes that we haven't seen some of those shifts, we're also learning why are some of those improvements not working? What can we learn from that and use that to further implement and make changes even better? So there's that real-time constant improvement, using data, real-world evidence, working with clinic partners to drive and support those change. And just a shameless plug, I encourage everyone to take a look at ADA presentations this year. There are going to be 3 presentations that would, share more details about 3 projects that will be referenced at this year's ADA. And we're very fortunate to even have 2 of those poster presentations highlighted by Kelly Close from the Close Concerns as the top 50 most notable posters. So please take a look at those, and I'm sure you'll find them helpful as well. In addition to ADA this year, we also have been presenting and will continue to present a lot of the results from the different QI initiatives being done in this clinic across different national forums, including NAHQ, IHI, and a host of other forums. So that's a summary of some of the work that's been happening in our QI collaborative, which is one of the 3 main aspects of the work we do with clinics. Now, the second section of that is our work around the QI portal, which, as I shared, it's an online product that integrates electronic medical record data into a secure platform, and physicians and researchers can now use that for population health improvement and generating real-world insights. So the homepage, this is the wireframe of what the homepage looks like. There are 22 different measures that are, collect evidence-based measures that was developed through a robust consensus process with different principal investigators on the clinic sites. So any site that is a full member of the collaborative and has gone through what we call the mapping process will be able to actually log in and see in very easy, clear way how they're stacking up against some of these measures. So how are we doing on depression screening, and how are we doing on CGMUs? So it gives them a lot of information they need, very easy to, in a very accessible manner. Sites are actually able to use this to create some of those charts I talked about, so the run charts or the control charts. And the importance of this is we know that there are times when numbers can change from one month to another, and some of those changes might just be what we call random variations. They might just be noise, nothing much to them. But what we want to do when we're testing implementation ideas, we really want to ensure that the changes we're seeing are real. So there are a lot of background formulas and statistical calculations that have been built into the portal to really help a site know if the changes they're seeing are real changes or if they're just random variations. But another interesting feature to the portal is clinical site can actually do clinic-to-clinic comparison with a peer. So if I'm a center in the East Coast and I want to compare how I'm doing with a similar size center in the East Coast, I can select that clinic if they are mapped on the portal and then see a real-time trend on how my data compares to theirs. And we do all of this friendly comparison to help promote that constant learning. So what typically happens after that is the physicians are able to hop on a quick call with another site like, hey, you guys are doing really well with depression screening or with CGMUs. Can you share what other things you're doing? You want to incorporate that into our practice. So we've created with this portal a safe space for physicians and practitioners in the T1D space to really be able to work together from moving away from competition to a very cooperative manner of using data to drive change and drive improvement. And they can also work with myself and our team of QI coaches at the T1D Exchange to help give them different tips. And we have a host of different resources that we're able to also help the clinics to improve on standard of care. So there's a section of the portal that's the improvement library that includes all of these fast-moving, rapidly evolving change ideas and success stories that's being populated into the portal as well. And then finally, for some T1D researchers or endos that want to even just take a deep dive on their data, they want to be able to create a table or create visualizations or run a chat, they're able to actually use the portal to answer those questions in a very quick manner. and all of these, they're business intelligence solutions on the back end. So our clinicians and researchers can actually use this portal and the visualization tool to create some really great insights that help them move the needle on the work. So all that is very exciting. And I talked about the QI data, and I talked about the portal data, and how we're using all of those pieces. So all that even helps us to be an organization that can work with partners to really be able to generate real-time insights and measure that, as soon as we can. And that fits into our work around the data insights and some of our impacts there. So far, just looking across the cohorts of the different data sets, this is specifically for the population health cohorts. This table just shows you like a breakdown by age category. Our data currently is skewed to more pediatric patients, but we've seen a lot of interest from adult sites that are interested in joining the collaborative and being a part of that. So actually, are focusing to have a lot more adult patient panel in this cohort as we expand. But we're able to work with the different PIs and researchers to answer very key relevant questions. So at this year's ADA, we'll be sharing a look at inequalities, looking at race and ethnicity, and race and ethnicity outcomes among patients with type 1. The recent news have kind of reminded us of just the disparities we've seen in different ethnic and racial minorities. And we're able to actually share that data from what we're seeing, looking at patients with type 1. At this ADA, we're also going to there's a poster being led by our researchers from Texas Children's Hospital, Dan DeSelva and co. I'll be looking at descriptors of CGM use. So what are we learning? What insights can we gather from who is using CGM, who is not, and how do we help improve the access to care there as it relates to CGM use from a population health perspective? There'll also be an additional poster on loss to follow up, and this list also includes different presentations that will be shared at other conferences beyond ADA later this year as well. And then this is just some of the ongoing manuscripts that's being led by a team of researchers to explore a lot of those different topics and really be able to get that out to the scientific community in a very collaborative manner that can help even promote our goal of really being an organization that is improving the lives for everyone impacted by type 1. And then I'll wrap up with just a few slides to talk about our ongoing surveillance study of COVID-19 in patients with type 1. And we do have more robust findings from this that we'll be happy to share with those interested after this webinar. We set out to answer 4 questions with the T1D COVID-19 study. And these are the objectives of the study. Our first primary reason for setting this up was to be able to actually have a system in place where we can keep track and monitor patients with type 1, either confirmed or suspected cases. How are they doing when it relates to COVID-19? What kind of presenting symptoms are we seeing? Are we skewed more towards a certain gender? Are we seeing more adverse outcome in a certain age? And then to also answer questions as it relates to outcomes. What are the outcomes and how do we take all of those findings to work with our clinical site to expand and scale that and then be able to actually have real-time insights to help move the needle on this work. And a big thanks and shout out to our sponsors and the logos displayed here. So thank you to Abbott, Dexcom, Lilly, JDF, Medtronic, Insulet, and Tandem, because they played a key role in actually helping us to be able to scale this study up and make this available for the T1D community. As of today, we have 48 centers across the country, and this map just shows you where each of those centers are located that have contributed or submitted at least one case to the online. It's an online registry with about 33 questions for any patient with a confirmed or suspected case. And there have been 210 cases that have been submitted as of today into the registry. This map just shows you, the tree diagram just shows you, the common symptoms we're seeing, highest of them being high blood pressure. So a little more than 50% of patients with confirmed cases or COVID-like illness are presented with high blood pressure. And that's followed by 39% of that is fever. and then 38% it's dry cough, and then 30 is nausea. And then the rest of the symptoms are much smaller category in this spectrum. Some just high-level summary of the findings. Over half of the cases have had no adverse type 1 outcomes. And by that, we mean diabetes ketoacidosis or severe hypoglycemia. So that's good news. We could all kind of be happy about that news. But on the flip side, more than 50% of patients with type 1 have actually been hospitalized. More of that for COVID-19-like outcomes. So, the respiratory and pulmonary concerns from COVID-19. And then some, a good chunk of that patient pool too was hospitalized for DKA. 38% presented with DKA, and about half of that was severe enough DKA to warrant hospitalization. We have seen a statistically significant association between A1C levels. So specifically A1C cutoff of more than 9%. We're seeing a remarkable worst outcome in terms of type 1 specific outcome, and for DKAs or severe hypo, but also in terms of COVID specific pulmonary outcomes for that cohort as well. Device use seems to be a protective factor, and this is kind of to be expected with the role device use like CGMs and insulin pumps help patients with glycemic management. And then unfortunately, we're seeing a significant negative association between race, so minority groups having more acute outcomes, and then patients on public insurance also having more acute outcomes. Some high-level preliminary findings were just published last week on Friday, and there's a link to that on this webinar. I'm sure our team will be sending out this slide deck and in PDF fashion, and also the link to this study after the webinar. So I encourage you to check that out. We also had some great coverage in the press for the early phase of the study. But now that we have over 200 cases, and that's still open, and we're encouraging our providers across the country to contribute and be a part of that, we're in the phase of doing more detailed analysis of the data we've received so far. And now we're working with a team of researchers that are part of this great work with the COVID-19 project to really explore and to be able to document in upcoming manuscript later this summer what are the outcomes for pediatric age groups. So Dr. Todd Alonso and anesthesia are working on that. Dr. Carol Livy is looking at the adult T1D outcomes. Myself and Dr. Hirsch will be looking at race and ethnicity and some of those disparities in there. And, close to a third of our cases has been from the New York region. So New York, New Jersey, and Connecticut. So our colleagues, Mary Pat Gallagher and Robert Rappaport, will be looking at the results we've had from there and what was some of the experience with just, being the first to be hit really bad with COVID-19. So all of those papers, as I speak to you, are active in process, and we just have a great team of researchers working with us to really be able to get out detailed findings to the community, by early September. And with that, I'm going to pass this on to my colleague, Dr. Wolf, to take this on and talk about some of the work with the registry and another aspect of our research.
Thanks, Osagi, and thanks for everyone who has joined us today. As Dave mentioned earlier, the Historic Clinic Registry was a seminal piece of data in terms of contributing to our understanding of both disease management and outcomes. However, there's still much more work to be done to improve outcomes for the entire T1D community. As a reminder, the clinic registry recruited participants from 81 different sites across the United States. The approach for the current T1D Exchange Registry uses a different model for recruitment, one which allows participants to join from anywhere via an online, mobile-friendly platform. The goals for the registry are outlined here, and they include creating a well-characterized cohort of individuals living with type 1, including underrepresented population whose disease prevalence is increasing. With this research-ready cohort, we also want to accelerate research by facilitating enrollment into studies and clinical trials. Further, we're gathering longitudinal data on disease, health status, and self-reported outcomes. And finally, one of our long-term goals is to align the registry with electronic medical record data from the Quality Improvement Collaborative to create a robust data set, including self-reported and clinic-based data. Registry participants provide self-reported data, which includes demographic information, socioeconomic status information such as education, income, and insurance coverage, clinical data, which includes date of diagnosis, A1C values, information about the care team, and family history of both type 1 and type 2, as well as some other conditions. In terms of diabetes management, we collect information on brand of insulin, insulin delivery method and brand, as well as BGM use, CGM use, and brand. Today, I'm going to provide a short preview about the registry cohort. As of end of May, there were over 8,000 individuals enrolled in the registry, and I'll be presenting on the majority of our participants with complete questionnaire data. As you can see here from this graphic on the right, the majority of our participants are adults and make up 87% of our population, and the average age is 38. We capture a wide range of self-reported conditions for the cohort, and a subset of those are shown here. There are over 900 participants who report eye disease or cardiovascular disease. And then further down this graphic, there are between 500 and 600 participants who report depression, anxiety, peripheral neuropathy, gastroparesis, or arthritis. In addition, we collect information on other autoimmune diseases besides type 1. This slide shows a subset of this data. So over 600 participants report hypothyroidism, and close to 500 report Hashimoto's or Graves'. In addition, 250 report celiac disease, which is commonly found in some people with type 1 with a specific genetic background. Despite enrolling participants via an online platform, you can see that we have strong representation of participants from every state and territory. Here you can see a heat map where the largest number of participants are in states with the darkest colors. In addition, we collect zip code data, which allows us to generate a more granular map to tease out participants who reside in urban or rural areas, as well as to contact participants by geographic location for studies that may require in-person visits in the future. Registry participants cover a wide spectrum from those newly diagnosed to those who have been living with type 1 for decades. Here you can see on this graph that 900 participants have been living with type 1 for 0 to 5 years, whereas at the other end of the spectrum, over 255 participants have been living with type 1 for over 50 years. So moving on to disease management, there are over 1,000 registry participants who rely on BGMs as their primary method of glucose monitoring. And we ask them how frequently they check their blood sugar. The results are shown here on this graphic. And what we note is that 50% test 5 to 6 times a day, and a smaller number, about a quarter of the participants, report testing 1 to 3 times a day. We know that within the cohort, there's a significant level of technology adoption. So if you take a look at the left-hand panel, there are over 3,800 current CGM users within the registry, and Dexcom products are most commonly used by this group. On the right side, we asked about insulin delivery method and found that 3,400 participants use pumps, 1,300 use insulin pens, and smaller numbers report use of syringes or inhalables. Of pump users, Medtronic pumps were most commonly used. We also capture specific information on brands. So this wraps up my very short preview of registry data. We hope to work with you on future research using this cohort. In terms of next steps, we want to expand the cohort so that it creates a much more robust and meaningful data set. We are also expanding features of the registry platform, including deployment of an annual survey, which will capture data that we expect to change over time, such as A1C values, and outcomes information such as DKAs, hypoglycemic, and hyperglycemic events. Also of note, we are launching a study promotion tool later this summer and a survey tool later this year. We're actively looking for opportunities to work with individuals to access the registry cohort and put its data to use through both study and trial recruitment, as well as deploying targeted surveys, which might go out to the entire cohort or certain selected subsets of the cohort. In addition, we're working with partners to spread the word about the registry to their constituents via our partner promotion program. With that, I'd like to thank all the registry participants for their valuable contributions as we seek to improve outcomes for the T1D community. For those of you attending virtual ADA, you can check out our posters to learn even more about our work. The registry poster shows data that I did not present today. And the next three posters highlight examples of work of our research team in partnership with different organizations for custom projects. So please take a few minutes, check out this great body of work. Now I'm going to turn the presentation back over to Dave.
Okay, thank you, Wendy. Hopefully that was a good snapshot of some of the work that we've done with both our registry and our QI collaborative. Just a couple minutes more, and then time permitting, we will answer some questions about questions that you submitted during the course of the webinar. So Wendy talked a bit about some future enhancements to our registry platform in terms of frequency and potentially linking and getting that intersection of people who are seen at centers in our quality improvement collaborative with those that we're gathering information from directly. And as we expand our QI collaborative, which is a major point of emphasis, that will naturally occur, but we'll also look at opportunities to do that elsewhere. On the QI side, certainly integrating device data is something on both sides, both registry and QI, that are of interest. And we've talked to some various companies that have data that's collected from patients' use of devices that we think will be able to provide a lot of richness to our data. And so we're in active discussions with that, and that is certainly something that we're working hard to complete. In terms of the QI data, we know from some of the adult clinics we've spoken to that they would be even more interested if we also had some ability to gather some type 2 data for them in a similar fashion as we do with the type 1. We are certainly evaluating that and how we do that and maintain kind of a separate effort, because our pure primary focus is on those with type 1 diabetes and moving the needle in that arena. But certainly that is something that we're going to do. In terms of partnering with industry, we do some custom research And, that is something that both on the qualitative and quantitative side, that there are a number of things we can do. We have active projects where we are doing interviews, focus groups, and surveys with our partners. Sometimes that may involve the data that we've collected from the registry of the collaborative in terms of analysis. Other times it is this custom data. So we do both sets. Here you just see a couple of snapshots where we were looking at differences between CGM and BGM users, or looking at glucagon and some of the perceptions there, certainly given some of the innovation that has taken place more recently in that space. And finally, I also want to thank the sponsors for the COVID study in particular. This was an effort that was not budgeted at the beginning of the year or planned for. And we recognize that we reached out to a number of you, at a time when you were facing your own issues, thinking about the patients and providers you serve, your own employees. And we know it was a difficult time to ask for you to divert additional funds over our way. But, thankfully, a number of you certainly saw the value in it, and we absolutely appreciate the fact that you were able to support us at a time when you have a lot of your own issues to contend with. So thank you again for that effort. And certainly, the COVID study is one part, but as you've hopefully seen over the past 55 minutes, we have a number of important initiatives that are undertaken. And again, we have a number of people who have helped us, who help promote what we do. We are trying to grow. We are in growth phase at this point. So ways for us to get more people with type 1 diabetes into our online registry is an absolute priority. And we get assistance from that with organizations like Beyond Type 1 and ADA and JDRF and College Diabetes Network, hopefully. So we are certainly, that's a big part for us. And some of the other organizations, that we're hoping to work with. And on the collaborative side, we're at 15 centers. We'll be at 20 by the end of the year. We want to get that up to 30 or 40, in the next 12 to 18 months after that. So we are, looking for ways to collaborate like we do in other efforts. Here, we think that we're focusing right now on areas that are really have some uniqueness. We have some expertise to offer, but we rely on, some of the expertise that a number of other organizations have. So certainly that's a big focus. And so in terms of contacts, for those of you interested in more information on the collaborative, you heard Osagie, there's his email, there's the URL for our COVID study to learn more, or if you're at a center that may be interested in participating, so we can get that up from 200 cases to 400 cases, let's say. It gives us a lot more ability to kind of do research. And then you saw some of the other contacts as well. So, with that, I think we'll turn it back to Rebecca to go through a few questions in the last 5 minutes that we've got.
Great. Thank you, Dave. Thank you, Wendy and Osagie. We do have a few questions that came in, so we'll use the last four or 5 minutes to answer those. I will direct the first two that came in to Osagie. The first question, Osagie, is around the COVID-19 study. How many patients do you anticipate getting by the end of the study in September?
We anticipate close to 400 patients. We're over 200 now, and we've been notified about local IRB approvals from additional sites. So I think that data will start coming later this week, early next week. So there's a good chance we're going to get to 400. That's our target.
Great. Thank you, Osagie. And the second question about the Quality Improvement Collaborative was, does my clinic need to have a certain number of type 1 diabetes patients to join the Quality Improvement Collaborative?
So yes, we generally want clinics that have at least 500 type 1 patients to be a part of that. And the reason why we have that limit is because of some of the work with data mapping and the data infrastructure that goes into that. But if it's less than that, I still encourage the clinic to reach out to us, and we'll have conversations on a case-by-case basis. But that's our threshold for the amount of work that goes into helping the clinic enjoy all of the features that we offer.
Great, thank you. And one more question that just came in around the CGM QI poster. Do we have the number of the ADA poster on that, or is that something we could send as a follow-up?
We can send that as a follow-up.
Great, thank you. The last question that's come in, Wendy, this is for you. As a researcher, how do I go about having the ability to query the registry cohort?
That's a great question. You can contact me directly and we can work with you to make arrangements for that.
Great, thank you. And I think we mentioned it in the presentations, but we will be sending out the slides to all of the participants on this webinar. We thank you for your time today and for listening to us to learn more about T1D Exchange and to all of the many opportunities we have to partner and follow up with all of you. Have a good afternoon and thank you for joining us.
Take care.